Hello and welcome to today's webcast, Building an Efficient Database for Your Research. Today's webcast is brought to you by Discovery, the Critical Care Research Network at SCCM. My name is Matthew Wannett, Clinical Assistant Professor in the Department of Pharmacy Practice and Translational Research at the University of Houston College of Pharmacy. I will be moderating today's webcast, and I have no relevant disclosures. This webcast is being recorded. The recording will be available to view again on the SCCM YouTube channel within 5 business days. There is no CE associated with this educational program. However, there will be an evaluation sent at the conclusion of this program. Your opinions and feedback are important to us as we plan and develop future educational offerings. We ask that you please take 5 to 10 minutes to complete the evaluation. A few more housekeeping items before we get started. There will be a question and answer session at the conclusion of the presentation. To submit questions throughout the presentation, type in the question box located on your control panel. You will also have the opportunity to participate in several interactive polls. When you see a poll, simply click the bubble next to the choice. And now I'd like to introduce our speaker, Dr. Michael Shashadi, Assistant Professor of Medicine and Associate Scholar of Epidemiology at the Perelman School of Medicine, University of Pennsylvania. Dr. Shashadi earned his MD at Vanderbilt University in Nashville and a Master's of Science in Clinical Epidemiology at the University of Pennsylvania. He is an active clinical and translational investigator with a focus on the acute organ dysfunction syndromes of acute kidney injury and acute respiratory distress syndrome in critical illness and lung transplant populations. Dr. Shashadi's research work is well published in the area of critical care. And now I'll turn things over to our presenter, Dr. Shashadi. Please take it away.
Thank you very much, Matt. And I want to thank everybody for joining us today for the webcast. I'd like to start the talk before we go through the objectives, just to give everyone some context so you know who's speaking to you. Matt gave the introduction. I am a physician investigator and I study the clinical and molecular epidemiology of organ dysfunction. It's important to know that I am not a data scientist, and you definitely do not want me as the lead data manager for your project. However, I do have long-standing experience designing, managing, and analyzing small to mid-sized databases. So I work with a whole team of people here at Penn. And I do have training in database management, and we've worked with paper databases, paper-based databases, REDCap databases. We utilize electronic health records here at Penn for bulk data, and our focus is mostly scientific research, some QI and PI initiatives. And I state here that I have enough experience to know the prolonged misery that comes with a poorly planned database. So hopefully that makes me qualified to share some wisdom about this, and I'm going to be happy to take questions at the end. So just going through the objectives for today's talk, I'd like to describe the planning process in creating a database to support human research studies, including variable selection and database design. I'd like to review data acquisition options to match accuracy and efficiency to the project needs, and then finally go over a basic approach to data cleaning, including automated checks and manual data review, and tips for constructing data sets for analysis. Now, because this is a 45-minute to 1 hour long presentation, obviously we're going to be scratching the surface here. There's much, much more that you can learn about database management once you get into it, but hopefully this will serve as a useful overview. So for starters, let's go into the planning process for database. And I'd like to start this with a question. We have a few questions in this presentation. The first question is, which is the best first step in planning a database? So we're going to open this up to responses. The options are create a variable list, create a basic proposal with study aims, create a data dictionary, or organize variables in the data collection instrument. We'll give you just a little more time. Oh, okay, good. We should have some results here from the poll. Okay, so 93% said to create a basic proposal with study aims, and 7% said create a data dictionary. So what I had in this was create a basic proposal with study aims. Now, realistically, you're going to be talking about doing all of these things as part of the first prep, but I'd like to go through at least my data planning process and make an argument as to why you should start with a basic proposal and study aims. Okay, so here are the steps I'm going to go through. Aims and related aims. I'll define what that means. We'll talk about the primary key briefly for your database. Then we'll talk about variable selection, and we will then go through data dictionary details, including variable grouping, naming, and valuing. So step one, figuring out the aims. I recommend deciding on your question first before you jump into database planning. It seems like a simple thing, but I have actually found it in reality to be quite hard and requiring discipline. Now, if you happen to have to write an entire grant first before even constructing your database, then you've already done this. But in many, many cases, that's not going to be the experience. And instead you have an idea and you say, I would like to start collecting data on something. It can be easy to jump in and start doing variables. But if you can put together a one-page document of study aims with some sense of the analytic approach, you'll be in much better shape. So I have an example below. This is not a full page. It doesn't have to be a full page. But I say, what is my question? My question is, what are the risk factors for acute kidney injury in critically ill trauma patients? And then I have a couple of aims here. I'm going to determine the clinical risk factors for AKI after major trauma, and then I'm going to determine the association of plasma nephcidin levels, nephcidin being a made-up fantastical AKI biomarker that is going to cure all ills in the AKI realm. And then my basic analysis is, here's how I'm going to compare groups AKI and no AKI, unadjusted associations, and then I'm going to plan to do a multivariable analysis. So I'm going to use logistic regression. So then how can that feed into understanding how I'm going to set up my database? Well, when we design research projects, we usually construct conceptual models, and the conceptual models can help a lot with the database design as well. So here we have trauma that occurs may result in the outcome of AKI. And then there are a variety of exposures that we are interested in. We're saying we want to identify the clinical risk factors. And so I made a box of clinical factors. It's sort of a preliminary list. And then at the bottom, there are molecular factors. So this reflects our two aims here. And you can see already a very preliminary variable list starting to form just through this conceptual model. Now, there's also something that I would call related aims, which makes sense to think about when you are going to construct a database, because you may have aims that are related that would utilize much of the same material. So let's say you also happen to be interested in clinical and molecular risk factors for ARDS. You might be interested in delirium. You may be interested in mortality. And then you may want to ask some of your colleagues, do they have related aims? You say, hey, I'm going to put together a database looking at risk factors for AKI and trauma. Do you have interest in anything that might use that population? And we find that that can maximize the scholarly and QIPI productivity, but it also, and this is an important consideration, it can help to share the database workload. If you have collaborators on this, and you may obtain some more if you kind of expand what you're doing, then you have more people to help work on your database. However, I recommend avoiding making the database the everything repository. You know, you go and you ask 50 people on your hallway, what do you want? And they all have their list of 20 variables that they want. And next thing you know, the database is way too large to manage. So keep it focused and keep in mind that some components can be added down the road. It's important to think through that beforehand to make sure what can be and what can't be added down the road. Okay, so let's say we now have consideration of some of these related aims. It's an updated conceptual model that shows we've added ARDS, delirium, and death as outcomes of interest. And then you can see in the clinical factors box, we've added some additional clinical characteristics that we might want to track. So chronic lung disease as a risk factor for ARDS, dementia as a risk factor for delirium, or certain other things like tidal volume or use of sedatives or this kind of thing. And then we have additional molecular factors, again, made up biomarkers that may help to heal the lung or may damage the brain that you add in. So you get a broader sense of what you want to accomplish with this database. So once you have an updated conceptual model, then you can go back into your database. You say, I have my aims now and a basic proposal that's covering things. And I say, how do I start to set up my database? And step one of setting up the database, now database planning step 2, is usually creating what's called a primary key. With modern database software, this is oftentimes done automatically, but it's important to know how this works, and it's a fundamental aspect of database management, or if you take any kind of course. So I have a definition here from the guy who taught me database management, John Holmes, that the primary key is an attribute or set of attributes that uniquely identify an instance of an entity, which is a little bit of a mouthful and can be somewhat difficult to translate, but I will try here calling it the fundamental unit of analysis, or some people call this the unique identifier. And it's different depending on what kind of project you want to do. So in some projects, the fundamental unit of analysis is going to be a single patient. And perhaps on that patient, you want to collect data on one or more hospitalizations. In that case, your primary key must reflect that single patient. And if there are additional hospitalizations, those will represent additional entries attributed to that primary key, the single patient. You may say you want to focus on a single patient hospitalization as the unit of analysis. That could contain data on one or more ICU admissions. So you have to construct your database in such a way that it allows for that. Or you may say, I want to focus on a single patient ICU admission. Therefore, it is not a single patient may have more than one ICU admission, but you will have different primary keys for that single patient for their different ICU admissions. And then you can say within that unit of analysis, you're going to collect data here on one or more ICU days. You need to think about what works best for your study. There's no one way to do it. And then typically you assign what we would call a study ID or a record ID to represent this analytic unit. Again, some database software will do this automatically for you, but the study ID is a unique identifier that is generated in some way. It's a numeric system, and we try to avoid using things like social security number, medical record number, name. There are several reasons why we don't want to use those. First of all, they may not be unique, so names are not necessarily unique. One patient may have more than one medical record number, which can create a number of problems. And of course, these also constitute PHI, and therefore they can't be used as the identifiers in de-identified data sets, which ends up being pretty important. So keeping a study ID as your primary key for your database is important. And then you can link that study ID to things like MRN or name or date of birth or other things that you need to include. Okay, so after you establish your primary key, then you can move on to the variable list. And this is coming in part from that conceptual model that we constructed before. Now we want to try to figure out a comprehensive list of variables. And this is where you just start writing a bunch of things down and you consult with other people. What are the variables? What is your wish list? Here are the exposures of interest. Here are potential confounders that, I looked in the literature to find these things, or I've hypothesized these confounders. What are the outcomes of interest? We talked about AKI, ARDS, those sorts of things. And then there are other details that may be important when you construct your database, like the date. You want dates of admission or dates of ICU admission, other administrative details. If you're collecting specimens like we're going to for biomarkers, you may need variables that indicate availability or collection of specimens. And then once you create this list of variables, or as you are creating it, you can create a preliminary data dictionary by category. We'll go through the data dictionary in a sec, but if you lump variables into different groups like demographics or admission data or medical history or these kinds of things, oftentimes that can help with thinking through an exhaustive list of variables that you may want to consider. Now, this isn't the final list, but it's important to kind of expand your mind when you're doing this portion so that you don't miss things that you go back later and say, oh, I wish we had collected that. So I have copied out a few lines. This is just a few lines from a very basic data dictionary that is constructed in Excel. And there are a few basic components that I'll go through here. You'll see in the first column on the left, there is what I'm calling a data set. Each line, each row in this is going to be a variable, and then I want to assign certain characteristics to that variable. And so certain variables will be in the administrative data set. Certain variables will be in the AKI data set, and you can have a variety of different data sets, demographics, et cetera, how you're going to group these variables. Then you have a variable name, and we'll go through a little bit on variable naming. You have a variable type, which we're going to talk about in the next slide, and the importance of understanding that for getting your comprehensive list of variables. You have a data format. Is it text? Is it an integer? Is it a date, etc.? Then there is a label which describes what the variable actually is, and then there are details of value and coding. Now, you don't necessarily have to have every last piece of this in a preliminary basic data dictionary, especially if you're using database software, because it oftentimes gets constructed automatically as you go along. I'll show you that in a few slides, but this is a good overview or a concept to have in your mind of what a data dictionary looks like when you're trying to list out your variables and some of the basic characteristics you need to be able to define for your database. So on this issue of primary versus derived variables, or you can use different terminology for it, but for me, I consider a primary variable one that has a value that's assigned through data entry. So if I ask the question, what is the tidal volume? And somebody types in 500 cc's, then that is just the variable. That's the tidal volume, and that's it. However, if I have a derived variable like acute kidney injury, I could ask the data entry personnel to say, did this patient have acute kidney injury? But that requires data entry personnel to go back and essentially apply a complicated algorithm to the data, and that's not what I want to happen. So instead, what I want to be able to construct this variable myself. But in order to construct the variable, I will need data that feed into it. So for example, for AKI yes, no, you need serial serum creatinine data. You need serial urine output data if it's available. You need renal replacement therapy data, and you need to know whether the patient has a history of chronic dialysis, because if they do, then AKI is going to be a not applicable variable. That's just for AKI yes, no. Staging and certain other things may require additional details. So after you go through that list and you can say, here are the derived variables and here's what I need to create those derived variables, then you're going to add your list of component variables for these derived variables in your whole big list of comprehensive list of variables, because you're going to need to account for all of those things. If you say I want to study AKI, then you better have a means to collect creatinine and renal replacement therapy and urine output and chronic dialysis. If you're going to study ARDS, you need to get ABG data, you need to get chest x-ray data, etc. And then once you have this big list of variables, you really do need to sit back, review, prioritize, and potentially cull the variables. So you kind of have a mind-expanding step at the beginning where you consider your big wish list. And then you sit down yourself with other people who are working with you, saying, do we need all of these variables? And the tendency at the beginning is usually to have a huge list and to try to collect too much. But you need to remember that more variables equals more money and more time, or money/time. And you want to know if there are specific variables that you could target to drop. So a variable that you might want, but you say, I'm not exactly sure how I'm going to use it, it's of limited marginal benefit, let's go ahead and drop that one because this database is already too large. If the collection of the variable is really onerous, so it may be an important variable, but you're looking through the medical record saying, man, it's going to be very, very hard for our data collectors to go in and get this reliably. You may say that's one to drop. And then there are other variables that if they're kind of, you're on the fence, would be nice, not 100% necessary, but if you can say, it's not that difficult to go back and get this later if we want to, that may be on the list of variables that you drop. However, if you have something that you say, this is our one chance to get it, and you're on the fence, then maybe you go ahead and include it. All right. So I want to move in. We kind of went through our how we come up with our list of variables, and now I want to ask a question about variable naming because we're going to start really detailing these things. So in the case report form on demographics, question 3A asks for the patient's first name. What variable name would you assign? And the choices are dem_3A, name_first, dem_name_first, capital N name _capital F first, and then this demographics patient name first, but not middle or last. Okay, so 10% of folks said dem 3A, 21% said name first, 62% dem name first, and then we have a few who are looking at the last two options. And I'm going to freely admit up front that this is, there is nothing absolute about this, but I will share with you my thoughts. Some of it is style. I ended up doing hey, there are two that I think are easily justifiable. Name_first or dem_name_first. And that depends in part on how much you value brevity with how much you value specific organization. But I have a few variable naming tips here, and then everybody is different as to how they do this. So I think that variable names should be intuitive, and that's my major issue with the dem_3A. The good thing about that option is that you can map it back to the database really well. You kind of know what question to go look at. The downside to it is when that variable comes out into your analytic data set and you're using the variable names for the code that you're writing to do your t-tests or your logistic regression or whatever else, those things tend not to have much meaning. Whereas if you want to look at the patient's name, it is easier to remember, oh yeah, the variable name for that is name_first. And again, the dem_name_first, the consistency and organization of the variable name, you may want to indicate for each of the variables what category they belong to. Sometimes that can be helpful for organizing your analytic data set as well. The reason that I didn't choose the option D is because, at least for the statistical program I use, which is Stata, the variable names are case sensitive. And it is a lot easier to type out things that are all undercase letters as opposed to having capitalized letters anywhere in the variable names. And then option E is sort of the most specific, but is clearly the least brief. And any variable that you name, and sometimes I've gotten into some pretty long variable names and then regretted it. At a certain point, you say, I need this to be shorter, and I'm going to include any other information in the variable label, for example. Now, it is important to be specific, and you want to think about, depending on your database, here are just a couple of examples. If you have a database of transplant patients and you are collecting data on donors and recipients, then you should not have a variable that is called race. You need to have a variable that's called race_donor, race_recipient, or something like that. And then if you have a project where you're collecting multiple kinds of sample, it makes sense to delineate what those samples are. So you want to be specific so that things don't get confusing. You say sample _ 24 hours. Does that apply to plasma? Does that apply to urine? And you try to be as clear as you can in the variable name itself. And that's not the only place where you can get variable characteristics. You can get them in a variable label, but making logical names is still pretty important. Okay, so another question about variables, this one on variable values. You create a variable called hmed_ACE for home use of an ACE inhibitor medication. What is the best way to code variable values? And your options are coding them as text, no or yes, coding them as text, no, yes, or unknown, as integers 0 and 1, 0 for no and 1 for yes, as integers 0, 1, and 2 for no, yes, and unknown, or 0, 1, 88 for no, yes, and unknown. Okay, so here nobody chose the text options. And then of the integer options, we had a 0, 1, and then we were sort of roughly split between 0, 1, and 2, creating an unknown category with 2, and 0, 1, and 88 for unknown. So again, with this one, I will agree with the group that I would not use text for these variables. I don't think there's a lot of debate about that, because when you get anything into the analytic phase, it is going to be much better to have these categories, any categorical variable, represented by a number, and then you just have value labels that tell you 0 equals no, et cetera, et cetera. The options here, where we have, and I think we have slightly different options on my version of this versus the version that came out. So I apologize for that. The things that I detailed here were, I think there was an option that some people had for the polling question that was 0 and 1 for no and yes. And in some cases, it makes sense not to have an unknown variable, but in most cases, it does make sense to have an unknown. And then I'm going to explain why I chose the 0, 1, and 88 for this. So some coding tips. As we said, numbered categories facilitate analysis. The reason that I choose, if you look at the options above, 0, 1, 88, as opposed to option E there, 1, 2, and 88, is that the values should be intuitive. So if you have a no, absent, or false, it makes sense to make that as 0, a yes, present, or true as a 1. It may be different for other categorical variables. So if you have race variables or gender variables, there is no intuitive value that says one should be 0 and the others should be 1 or 1 through 5 or something like this. But for anyone that's set up as a no, yes, I recommend doing 0 for no and 1 for yes. And then specifying the unknown can help. It can help when you're looking at the data to distinguish between the data entry personnel said, I looked for this and it's not obtainable. And so they actively have to click the unknown option. And it also gives them an option to click. It separates that from they just missed the question. They were going through the collection so quickly that they forgot to enter a value for that. So I recommend actually specifying an unknown. And then the reason that I chose 88 for the unknown is that it is probably best when you're going back in to do your analysis that you have a check that tells you these are implausible values. So 8 or 88 or something like that, in this case, there's a clear difference from the actual values that are answers to the question, 0 and 1. And that's a prompt to you not to miss the fact that you are accidentally accounting for unknowns in your analysis. So if you have a continuous variable like heart rate, then you have an implausible value that you put in as an unknown. 8888 would work in that kind of circumstance. I've seen databases, I've worked with databases where, for example, 97 was used as the unknown value, but that was included as the unknown value for continuous variables like heart rate or systolic blood pressure, where those are plausible values, and it creates problems when it comes to analysis and cleaning. Okay, so once you have created those the variable names and the value labels, now you want to finalize your data dictionary. So the preliminary data dictionary, I think it's fine to use something like Excel if you just want to sketch some basic things out. Once you get to the point of doing a comprehensive data dictionary, you can do that in Excel, and that works. You can certainly do that if you're using a paper data collection instrument. But as I mentioned before, for electronic database programs, the data dictionary is often created as you build the data collection instrument. And so you don't have to go back and finalize it. Instead, what you do is you start constructing your database, and as you construct it, then you can look at your ongoing data dictionary. So for example, REDCap, which is the software that I use, although I'm sure other software programs have something similar to this, will have a data dictionary that you can pull up at any time that has variable name. So here's like patient ID, PID, height, weight, etc. Here's the variable label describing what it is, as well as some of the details of what is asked of the data enterer. And then there are the field attributes. So REDCap ends up considering numbers in their quote-unquote text field, but you can see it's an integer. So the patient ID is an integer, and it starts at this 200,000 or 200,000. And then again, you have numbers for the height in centimeters or for the weight in kilos, and then different kinds of buttons. Here are radio buttons with 1 for yes, 0 for no, and 8 for not obtainable. Okay, so that is a little bit of the planning process, and now I'd like to move on to reviewing data acquisition options that match accuracy and efficiency to the project needs, understanding that there's going to be a natural tension between these two things. You can't have a 100% accurate database or data acquisition plan that is also 100% or perfectly efficient. So there's some degree of trade-off, and the idea that you want to get is how to optimize that and also match it to how badly do you need accuracy versus how badly do you need efficiency. All right, so a few things with data acquisition I want to go over: data collection methods, platforms for manual collection, data entry procedures, and then brief comments on test cases, backups, and security. Okay, so I've detailed some data collection methods here, which I've termed manual and electronic repository. And what I mean by electronic repository is obtaining bulk data from some kind of electronic database. Now, in my experience, this is largely obtaining bulk data from electronic health records that we have at our institution. But it could apply to larger databases, Medicare databases, other things like this. And approaching data collection from these two different kinds of sources involves some benefits and some risks. So for manual collection, there is an accuracy component that has to do with cognitive checks, meaning when a data enterer is going through and recording some of the information, that is a thinking person who, if he or she knows a little bit about the variable at hand and about the medical record, then that person is going to be able to go through and say, does this make sense? Or am I entering the right thing for this person? Manual data entry tends to be intuitive in part because the database and the data entry platform has been designed in such a way, or the interface, I should say, has been designed in such a way that it is easy for people to go through. And in fact, they have instructions, and you want to make it like that so that it's easy for any data entry personnel to come in and intuitively understand what they're doing. And in some cases, you can get early error identification. So if somebody's going through the charts and they start noticing an unanticipated problem that's getting in the way of answering one of the variable questions, then they stop, they go to you, they say, hey, this is what I'm finding. You didn't account for this before. How do we want to address this problem? There are minuses to manual data collection as well. You can certainly have keystroke errors. We always have some of these, entering dates or sometimes even entering an ID number, medical record numbers, other things like this. It is a labor-intensive process. You need people to go through and do it. And the reason that I term it inflexible, it's only inflexible in a certain way, and that is you set up your database, and then for people entering those data, that's what they're going to enter. So if you say, I set this up to obtain 5 days worth of creatinine data, you're going to get 5 days worth of creatinine data. And it is relatively inflexible to saying, let's change that and get 30 days of creatinine data. Now, for the electronic repository, there is an accuracy to that as well, in that things are generally fairly uniform as they come in. They tend to be comprehensive. You have access to many more variables usually in such a case. And then they can be scalable and therefore efficient. So if you are able to design the manipulation of that electronic repository in a way that you kind of take the data coming in and then you spit out what you want, applying that to a much larger number of patients becomes not too difficult. And then there's a flexibility, as I said, with being able to choose additional variables. If you say, I actually wanted these 10 other medications, that's fine. You just go back to this big pool of bulk data and pull them in. But there are minuses as well, what I term activation energy, which means you can't just take the data and take a look at them and you say, yep, that makes sense to me. And now I have a sense of the following variables because I already designed them in an intuitive way. Instead, you have to spend time actually constructing the code to translate the variables from this electronic repository into something that's understandable to you. And you have to understand that it's repurposed data. So these are not data that are specifically collected for research, unlike the manual data collection. There may be hidden errors. It can be very difficult to notice some of these things unless you know exactly what you're looking for. And there's less investigator control in these cases, meaning, as an example, your health system uses Epic, like our health system uses Epic. And at a certain point in time, they say, we're changing the way that we're collecting this or that variable, or we're discontinuing the collection of this variable, or we're adding this, or whatever else. That is not under investigator control. You kind of take what you can get. So just as a couple of examples here, we have found an advantage to manual collection of arterial blood gases for ARDS. Why? Well, first of all, ARDS is one of our primary outcomes, so it's really important for us to be accurate. The electronic health record, at least ours, tends to have a lot of mislabeling of venous blood gases as arterial blood gases. Therefore, you're getting PaO2s that are in the 30 and 40 range that are easily going to qualify someone as having ARDS, except it's not an arterial PO2. And then it's very common for the FiO2 to be inaccurate in such cases because in order to get it run, you have to enter an FiO2, and if the person can't remember it, they just put 0. So in this case, you say you do a manual review, you can look at multiple data components, and then you can say, here is my actual ABG with an accurate FiO2, which is critical for making that ARDS definition. However, I would say that for AKI, if you want to look at serial serum creatinine data, there is probably an advantage to using bulk electronic data because you have complete lab data with date and time stamps that is not susceptible to the keystroke errors. And once you have your query built, which can take a while, it is easy to vary the interval of interest. You want to look at AKI for 5 days, 10 days. You want to use different data for baseline values of creatinine, et cetera. It's fairly easy to then apply that. Okay, most databases ultimately incorporate both methods, and then you kind of combine them. It's important to determine upfront as much as you can which variables will be obtainable from the repository. Because if you're confident that you can get them from bulk data and actually use them, then you don't need to include those in your manual database design. But if it's really unclear whether you can use them, you may want to include them in that design. So then going through some of the collection platforms, I call paper the least desirable, and here is a piece of a data collection form that we used to use up through about 2010. You can see that I did not design it because the no options are given a value of 2 rather than 0. But what you have to do for this is you have to go through, do it by hand, and then someone needs to take this and hand enter it into an independently constructed electronic database. The more steps you have here, the more possible errors. Sometimes you need to use dual data entry to try to address some of those errors. So there's a lot of work with paper collection. You can use a spreadsheet program like Excel. It's fairly accessible, and for a very simple, small data set, I think it can be usable if you say, I don't want to go through the process of creating a whole database in database software. But ID and data integrity is a major concern. So Excel just lets you do a little bit too much, and it doesn't necessarily enforce that this study ID has to stay with these data. And if you use the sort command incorrectly, all of a sudden, all of these rows get switched up, and then you have completely lost your data integrity unless you have a previously saved version. You can create some relationships between tables manually, but it's more cumbersome than database programs. So then there is actual database software. And as I mentioned before, I have used REDCap, but there are multiple other options that are available. And these have a relational database structure with referential integrity. So you're going to have things that all of the data are going to be linked to this unique identifier. And in fact, data in different forms or different instances will have both that unique identifier and sometimes a secondary identifier enforced. And they tend to have a user-friendly interface. So this is just a list of some of the quick tasks that you can get from REDCap, including the data dictionary, which is the code book, click to export the data into various stats packages, creating reports, building data quality rules, etc. We'll go through a few of these in just a second. All right, so then you want to go construct your database. And now we're going to go back to that variable list. So I would say step 1, you can create forms and sections from the data dictionary category. So let's say you have a demographic list of variables. You may want to make that a form or a section within your database. Sometimes you want to mix these up a little bit depending on whether it makes sense for data collection. So I say you may want to group the variables that share a location within the medical record so that when data entry personnel are going in, they can collect all of those variables at once and they're all in the same form or section. And then you want to populate those forms that you've created with these variables using the names, the values, et cetera, that you've decided on from the data dictionary. And in something like REDCap, there are several different interfaces, ways to present these. So for example, for this GCSI opening, there are radio buttons. You end up choosing one. Some of them you can do as drop-down boxes. Some of them are typed entry. And here's a little reminder to people to put 8888 if it's not obtainable. And then you can consider more advanced functionality depending on what you need in your database. So branching logic is something that can be used to avoid illogical entry. So if you have a question that is a follow-up question, that is what type of diabetes mellitus, you only want that answered if the answer to does the patient have diabetes mellitus is yes. Whereas there's nothing preventing answering no to diabetes mellitus, but then entering type 1 for what type of diabetes if you're on a paper form. You can also construct repeating instruments. Some of them may be scheduled. You say, we know we want to collect the vital signs each day for the first 3 days, or some that are flexible where the user can enter a number. How many ABGs were performed on this study day? And then here's ABG1, and down below it will automatically populate space for ABG2 if you entered 2 up here, what have you. And then manual procedures can be really helpful, especially if you have multiple data entry personnel, but it's helpful even if you're just doing this by yourself. It includes the data collection details for each variable, how you define the variables. You can list examples, and oftentimes it directs where to obtain the data, where in the medical record. So here's one from an AKI and lung transplant project that we're doing. This is defining vasopressor use, and we're defining it as these different vasopressors. And we have a specific comment that we don't want to include what would be referred to as renal dose dopamine because some of the surgeons involved in the project end up using that, and we don't want to count that as vasopressor use for the purposes of our project. There are benefits for data collectors. They have guidance, and then you have some uniformity, but also benefits for the investigator because you have to think through the details beforehand. And then when you go back to analysis and you're saying, how did we define that? You just go back to your MOP and you say, that's how we defined it. Now, it does not have to be in excruciating detail. Even a basic MOP can be helpful. And then a few other items in your plan. Once you have the database and the MOP constructed, both you and any data collector should try some test cases to make sure things are working out how you hope. Then you go back and you revise, and then you kind of put out your final product that you're going to use. It is important to at least think about backups. If you're at an institution where you can save things on a shared drive and the shared drive is backed up once a day, then you may be in okay shape, but it is important to take a look at this, where you're storing the data and how you can make sure it's backed up well. And then security is also important for these databases. So Excel database files can be password protected, but for electronic database software, usually you can set user data access permissions. So for example, in REDCap, this user rights button, where you can delineate what different people are allowed to do on this REDCap project. Okay, and in the last few minutes here, I want to talk about data cleaning, data checks, and manual data review, and try to leave some time for questions. So, but I will ask a question first. On data cleaning, which of the following is least likely to balance accurate data entry with avoidance of data entry errors? So, including pop-up flags for out-of-range variable entries, providing unknown and not applicable options for certain variables, periodically reviewing summary data for each variable, or avoiding out-of-range flags for data entry personnel. Which of these is least likely to help, or which of these do you not want to do? Okay, so we have a few people talking about the pop-up flags and periodically reviewing the summary data, and then most people saying avoiding out-of-range flags for data entry personnel, and then a number of other folks saying providing unknown and non-applicable options for certain variables. So then I'll go to my reasoning. So I have said avoiding out-of-range flags for data entry personnel. Now, there are arguments for and against all of these things, except for perhaps C. I would say that periodically reviewing summary data for each variable makes sense. Looking at means and medians and ranges and looking for out-of-range things on the part of the study team, that's going to be important no matter what. As we said before, the unknown and NA options may not work for certain variables, but in many cases, it is important to have those. And then the question of pop-up flags. In my opinion, having a little bit more prompting on the data entry end can save you a lot of work on the data analysis and cleaning end. So completely avoiding out-of-range flags for the data entry personnel misses an opportunity to catch keystroke errors. And oftentimes, that's what they are. Now, if you apply pop-up or out-of-range flags and your data entry personnel are finding that they're popping up constantly and getting in the way of their efficiency, you might revise that. But for the most part, having some flags that end up being soft stops can be helpful. So going into your data cleaning plan, if you have unusually high, low, negative values, this kind of thing, implausible dates, those are things that you may want to put. So here, as an example, for the height in centimeters, minimum of 100, maximum of 250. It helps people to remember that they're supposed to be entering it in centimeters, if they just happen to start entering it in inches instead. However, they're not usually hard stops. So somebody can override these. And of course, if you use something like 8888 as unknown, then they need to be able to override in the unknown cases. Some other things that you can provide: prompts for unanswered questions to make sure that they actually saw the question, they realized they missed something. And then in REDCap and other programs, you can build automated queries. So the data management team designs the variable queries. You can send an intermittent query report to the data entry personnel for anything that they've entered, and you can say, please review these cases. They're different from what we expect. And they can go back through. And so it creates this automated cleaning system where you don't necessarily have to wait until you get the whole team together to review everything. It's still important to do direct review by your data management team, which may be you, or it may be you and multiple people, where you look at every variable, you look at the averages, the ranges, the level of completeness, and you also want to figure out, do the data make sense? So as an example, let's say you did a 3-month review in this trauma cohort, and you saw 75% female and 25% male enrollment, which is the inverse of the typical distribution. And then maybe you go back to the database and you say, oh, we identified a problem here where we reversed the gender designation. Or people are entering it incorrectly for some reason. That's the kind of thing that really, it's hard to automate that, but it's an important reason for overall review. You can look at these by creating them in your database software, like creating reports, but you can also download the data. And prepping your database for analysis, I do recommend considering exporting the data from the database software to statistical software for review during this cleaning step. You may identify during such a step any issues translating the database structure into something that's an analysis-ready file before you say, okay, 2 years in, we're going to create our analytic data set. Further, for analysis, you're going to have to construct those derived variables. So now you have to take those component parts and you need to write a program to create the derived variables. And then you need to go through and do some kind of validation. That's certainly preferable against the primary data, test logic rules, but I definitely recommend having clean component variables before you construct and evaluate the derived variables. And then finally, you can create a basic analytic file. Now, there are many analytic files that one can create, but sometimes it can be helpful to say, I have a core set of primary variables that I'm going to export, and I'm going to merge in core derived variables in what's called a wide format. So 1 row of data per study ID for just basic analysis based on that study ID as the unit of analysis. And I listed here an example here. Programs like REDCap will export the data to a variety of statistical analysis software and then recreate what you have already entered. So it will keep your variable name, but it will also apply your variable label so you know what it is. And it will also add in your value label so that in that analytic software, you can see that 0 is no and 1 is yes and 88 is unknown. So in summary, I would say the database construction and management take discipline. Good planning is really key, but I would encourage you not to be afraid to make mistakes and then learn from them. And newer software, I have found REDCap to be quite accessible even for beginners, but one of the most helpful things is just diving in to get some experience so that you start figuring out how to utilize this. And then I am happy to take questions.
Awesome. Thank you, Dr. Shashadi, for a very informative presentation. The Q&A session, we'll start that now. So if you want to utilize the chat box to type in your questions, and I will triage them and send them over to our speaker. But I'll get it started. What do you think is the biggest mistake someone can make as they are setting up a database? So, trying to save them time from having to go back. What's probably the most important thing they should do as they're setting up the database?
Well, I mean, I would go back to the step one that I proposed here, which is I think that you make a mistake if you don't clarify what you want to get accomplished with the database. You really need to figure out what you want to do, because if you don't have a clear purpose, then the database, you're going to find yourself doing a lot of work, potentially collecting a whole lot of variables that may be unnecessary, but then also, and this just absolutely kills you, when you go through, you didn't define things in the first place, and somebody or some people do a lot of work to collect data, and then you get to the analysis and you say, we forgot to collect the following thing. And then you say, I can't even answer my question if I don't have this piece of information or these pieces of information. And that all comes back to the original planning and really getting a comprehensive approach up front. So I'd say that's the single biggest thing.
Okay, and what can you do when you're looking to collect data across a variety of healthcare records? So say it's not just Epic, it's a multi-center study, and you have a variety of different data being put into your database. Are there any recommendations for that?
So if you're running a multi-center study, I think you have two basic options, and it can be a combination of the two of these. If you want data that are, sort of your core data that are simple and doable by the people who are participating, you can put those in a manual collection database. And something like REDCap can be used, and people can access it easily. It's web-based. People can access that from other sites, and they're going to enter the data if they feel like they can give that investment to provide that basic level. And then you're going to say, all right, what other data might we like? And depending on how important it is, but it may be more onerous for the sites to collect, they're not being paid enough or they're not being paid anything, then you say, all right, let's just see what we can do with your bulk data. And that involves a lot of back and forth. It's best to figure out, I think, how you process bulk data on your end first, so that you have some experience with culling such a database and feeding it through a program to create derived variables. But then it's going to be different. Even if the other sites all use Epic and you use Epic, there are different ways to extract things out of Epic. And so you have to be willing to be very flexible and to have the other sites, engage enough that they'll say, yep, we'll keep sending you stuff. And then you send us commentary back saying, well, that's not quite usable, but can you vary it a little bit, and then we can work with it. And then you have to sit down and you have to write a program potentially for each site to do it. That's what we're running, a multi-center study right now, and that is basically the approach that we're taking.
Is it relatively easy to import data from an EMR into REDCap, such as Epic? You absolutely can import data from, for example, a spreadsheet into REDCap. Oftentimes that involves creating the fields the way you need them to be in REDCap. So when you import the data, everything is assigned appropriately. I think the thing is, at least for our electronic health records, there's very little that comes out in such a clean way that you can just sort of press a button and say, obtain all data, transfer to REDCap. When we look at vancomycin, we want to look at vancomycin and the risk of vanco associated with acute kidney injury. It turns out that there are 25 different ways to order vancomycin within Epic. And so figuring out, and then saying, I'm only interested in IV vancomycin. So I need to actually look through that data dump that I get
and say, here are the actual orders that I want. Here are the fields that have been constructed, and then I need to match those fields with what I have in REDCap. Alternatively, though, I will say, because you don't have to put everything in REDCap, sometimes what you can do is use database software for your manually collected stuff, and then merge everything else together in your analytic file. So you use Stata or SAS or something like that, rather than needing to upload everything to REDCap.
All right, another question we had come in. Some data collection forms include a comments text field where you can document unique features about a case or a patient that's not accounted for in the form. In addition to periodically reviewing this collected data, any advice for implementing this in a more efficient way?
I mean, I think that we have definitely used comment fields as long as you create them essentially as separate variables. What you don't want is you don't want confusion with the answer to your question. So let's just say, as an example, I'm constructing a database for rapid response for clinical emergencies for our hospital. And I want the reporter to be assigned. So we have a list of reporters, and but we don't always have everybody on the list, and I have new hires that come in. So then we include an option for other, so they can click other, and then there is a separate variable that's a comment box where they can type in their name. Now you could imagine this in any number of different ways. But I think that having a comment box enables you to have some of that flexibility that I was talking about with the manual data collection, where you can have early identification of exceptions and whatnot. And this gives the data entry personnel an option for typing something in, ascribing it to that record, and they don't have to immediately tell you. But instead, they can say, well, I noticed 5 different records that had some weird stuff going on. Let's look at the comments in them, because I put them down. So I actually think that it is a good thing to use for any variables. If you sit down and think about it, you say, well, there may be questions about this one, or there may be answers that don't quite fit into the options that I've given. Sometimes giving an other option and then allowing people to do comments is a good way to address that issue.
All right, I think we'll do one more question. So the last question, how do you keep large data sets updated in real time? Do you have electronic systems feeding them, or is it a every 1 week or every 1 month review, add, etc.?
So this is a balance between what your needs are and what your resources are. So for us, as an example, if we want to update our data in one of our critical illness cohorts on acute kidney injury, as long as we have the code constructed, that's a relatively easy data pull to do and code to run to update that database. So we might do that every 3 months, maybe every 6 months, something like that. You could do it more frequently than that if you needed something that were immediately up to date, but most of the time we don't need something that is right up to the moment, up to date in that way. So I would say we have never updated from EHR sources in anywhere close to real time, 1 week, 3 weeks, something else like that. And I think that can be complicated to do unless doing your data pull is really simple. In our cases, we actually have to make a request for the data pull, and there is always, even if you've made the same one before, there's always something of a turnaround, a week, a couple of weeks turnaround to obtaining the data. So that's about as close as we can get to real time, but frankly, we haven't needed it quite that close. I think what you don't want to do is you don't want to set up a system where you're going 2 years or 3 years or something like this, because then you will miss problems that may be cropping up, especially with respect to any changes that have occurred in the EMR.
All right, that's going to conclude our Q&A session. Thank you, Dr. Shashadi, for a great presentation, and thank you to our audience for attending. Again, you will receive a follow-up email with a link to complete an evaluation. There is no CE associated with this program, However, your opinions and feedbacks are important to us as we continue to plan and develop future educational offerings. Please take 5 to 10 minutes to complete the evaluation. That concludes our presentation for today. Thank you.